Like Dan said, I'm Courtney Strong, and I just want to say thank you, first of all, for the invitation to be here today. This is such a wonderful event, and I think, just having the introduction to, sure, closer to the mic, having the introduction with the members wellness program here, previously the lawyers assistance program, I've really felt appreciation and admiration for the attention to this particular issue of addiction that they're prioritizing, so I appreciate that. I also just want to say, next slides, share a little bit about what I'm going to talk to you guys about today. My intent and what I was asked to provide today was some of the nuts and bolts, something a little bit more practical. As addiction has gotten more attention in the media in the last several years with the opiate crisis, we have really seen that we're hearing about it, we're learning about it, but I think oftentimes what's missing in those conversations is, so what? What if you have someone in your life that is struggling with this issue? What if you yourself are struggling with this issue? Where do you go for support? How do you know how to navigate treatment options and solutions? So that's what I'm here to talk about, and I hope that it can be useful and concrete for you guys today. I'll give a little bit of an introduction about myself and my history. Again, my name is Courtney Strong. I'm a licensed mental health clinician and a chemical dependency counselor, which is a designation in Washington State for substance use professionals. And like Dan said, I started in the field actually in 2009, got my master's in mental health counseling. And at that time, I thought I had my dream job being asked to provide mental health services for felony drug court in Tacoma. And when I was given this opportunity, the job that I was offered was to be the sole mental health practitioner in veterans, family, and felony drug court. So it was quite the task, and I was brand new and green to the field. I had no idea what I was doing. And I really got this kind of quick exposure to the lack of resources, the lack of support, and complex trauma. So I spent a couple years kind of conceptualizing and institutionalizing mental health services for a broad range of folks that had really never had the opportunity to get treatment services in the past. I also want to say that I come into this from a personal history as well. I am an impacted family member. I got into my journey, my own personal recovery on the family side of this issue back in, 2005. And so that does kind of my personal story impacts and has impacted my bias throughout this history here. In 2012, I came into Edgewood, and we started Edgewood with the intent to provide substance use treatment to folks who were motivated to have an experience with treatment and recovery. So folks that who may be professionals who are looking for an anonymous, confidential place to get their services that they need, people that want to have an experience with sobriety and recovery. After 2 years, I was moved into the director position, and since that time, we've continued to grow and develop. So there's a poll in front of you. How many of you guys have known someone with a substance use disorder? Many people here in our live audience, and we'll get some details in a minute as well. One thing that I actually didn't put in our slides today, but I thought I would just go over with you guys briefly, and then I'll come back to who among you guys have had an experience and know someone who has struggled with addiction. But I thought I'd just go ahead and go through the criteria as well for the criteria for a substance use disorder. This has changed with the DSM-5. It's now a spectrum disorder, similar to the gambling disorders as we were just talking about for those of you who were with us in that previous presentation. And it's out of 11 criteria. So you have to meet 2 out of these 11 criteria to meet the criteria for substance use disorder. I'll run through them quickly. 1, taking substances in larger amounts or over a larger period of time than was intended. 2, persistent or unsuccessful efforts to cut down or control your substance use. 3, excessive amounts of time spent obtaining, using, or recovering from the effects of the substance. 4, a craving or strong urge that's endorsed by an individual who uses a substance. An inability to carry out major obligations at work, school, or home. 6, continued use despite persistent or recurrent social or interpersonal problems that are caused or exacerbated by the use of the substance. 7, stopping or reducing important social, occupational, or recreational activities due to the substance use. 8, recurrent substance use in situations which are perceived as physically hazardous, which is where we get our drinking and driving. 9, consistent use despite exacerbating physical or psychological problems as are a result of the substance use. 10 and 11 really speak to the physiological effects of substance use disorders, which is both the phenomenon of tolerance and withdrawal. So do we have the poll results from online?
88.9% said yes, I do, and 11.1 no, I do not.
Thank you. So, similar to the poll in the room, right? Most of us know someone. Most of us know someone who have had a substance use disorder. Some of us have had one ourselves. And it's in varied degrees in terms of how close we have been to that impact. But most of us know someone that have had a substance use disorder. Statistics tell us that 20% of the population, on average, suffers with addiction. There are certain cliches that come to mind when we think about addiction. We think about the street drunk or addict who, is on the side of the road. This is an image that has come to mind for people for years and years, for decades, and this isn't who I'm talking about today. And this is actually a myth that I have felt very, very passionate about trying to destigmatize over the course of my career, and I think that's becoming more and more prevalent socially as well. But today I want to talk a little bit about kind of the myth of the functioning alcoholic, particularly within law, attorneys, experts. I was thinking about coming here today and speaking to this population, and attorneys are a particular breed who are set up to be in control, incredibly brilliant, fascinated with articulating things in just the right way. And really, that population, and you guys know this intimately and more intimately than myself, when I think of someone that has a substance use disorder and you're taking those characteristics alongside of it, it's a population that's set up to really protect their substance use condition for a good amount of time before other people can see it. So we're going to talk a little bit about what that looks like as it begins to impact people's life and professionalism. Typically, these substance use issues, they begin with one person, impacting one person. It starts with someone who's self-medicating, struggling with a substance use disorder, and at first it begins as a person's personal affair, right? Eventually we see that this bleeds into people's family systems, and while people may be maintaining at work, school, home, their most intimate partnerships, their most intimate relationships tend to start getting impacted. We see that, as an impacted family member myself, and also as someone who works alongside families when they try to get their loved ones into treatment, we see that the kind of impact it has on loved ones is actually quite parallel to the kind of impact it has on the person personally suffering from the substance use disorder. The way that it manifests in their personal life, it may be that they're preoccupied, they're forgetful, they're finding that they're out of control, they're finding that they're chronically distressed, and these things kind of run parallel from the loved one to the person struggling with the substance use disorder directly. As it kind of continues to progress, we see that this ultimately does bleed into people's professional life. As you might remember when I was just reading the criteria of a substance use disorder, one of those criteria is directly looking at impairment with work, school, or home. Seeing that this is chronically beginning to impact someone's professional life. One thing that Dan had mentioned to me was that oftentimes he receives calls from individuals who are expressing their concerns for someone on the opposing counsel, or someone who may be seeing someone else that they work with in their particular law firm. And it may not be that someone is reaching out specifically for themselves, but instead saying, hey, I'm concerned about this person's performance. And it begins to become more obvious to those people that are surrounding those individuals. So there's another polling question. How many of you at some point in the last 2 years have been concerned about substance use in a colleague or in yourself? A couple people in the room. All right. We'll get some results. So in the workplace, part of almost the definition of professionalism is that we keep things buttoned up, right? We know this is what we're supposed to do. We're culturally ingrained to show up, have it together, leave your personal stuff at the door, come to work, get your work done, right? This is something that our society has really reinforced, and it's something that we're trained to do as professionals. I think in particular when we think of sort of more high power or high profile careers, physicians, attorneys, healthcare professionals in general, we tend to see quite a few folks in these categories that come to Edgewood and come to treatment with us. And I think that in some ways it can be more challenging for these individuals to ask for help, because there is this concern around confidentiality, around, is this going to impact my career? Is someone going to recognize me, right? And so we notice that as this is the case, it is a barrier for people getting treatment. We also know that while we may have cases where we're concerned about a colleague or someone that we know professionally, it's not quite water cooler talk to go up to someone and say, hey, I saw you at the holiday party and you seemed kind of trashed, right? This isn't something that is commonplace for the work environment, again, with that professionalism. So if maybe, do we have the results of the polling question?
Yes, it was 66.7 yes and 33 no.
Okay, that's pretty high. 66% of folks who have concern over someone that they've worked with that has had some concerning substance use behavior, possibly themselves, right? And so that's something to look at, and I'm glad to be here today, and I hope that this can be a useful conversation for those individuals out there that's answered yes to that question. What I want to kind of provide you is a little bit of a look at what does this look like, right? So someone's Most of the time, people aren't coming into work with a bottle of whiskey. Sometimes people are coming to work with a bottle of whiskey, but most of the time, they're not coming to work with a bottle of whiskey and saying, hey, let's go, right? What typically is happening is that this is a little bit more under wraps. People are showing up, they're showing up late, they're having a change in how they show up at work, so maybe their work performance has shifted and they're missing some details, they're forgetting things. We may also notice mood swings, a change in work motivation. We also might start seeing changes in someone's health. Their grooming may be sacrificed, and just generally odd behaviors. Leaving work in the middle of the day for no apparent reason, things like this. So what we're looking for is impaired control, social impairment. So maybe at that holiday party, people are showing up a little unusual from their typical stance. Risky use, where they're making decisions where they're drinking and driving, or there is this phenomenon of tolerance or withdrawal. You might not always see tolerance and withdrawal at the workplace, right? So as we're kind of considering how this might show up at work, what I would consider you to look at is really just shifts in behavior. How does someone show up at work, and if they're showing up in a way that isn't true to who you have known them to be historically, maybe there's something going on. I also just want to pause and say that it's often that, similarly to someone not wanting to recognize or come forward and say, yes, I have a substance use disorder and is an attorney and at work, they also may be just as disinclined to come to work and say, hey, my son or daughter is struggling with heroin addiction. And as I was mentioning before, those loved ones may have the same kind of impairment. The distraction, preoccupation, feeling out of control and not wanting to or not feeling safe talking about it. So my hope is to kind of look at how would we actually talk to someone about this kind of issue if you're noticing it in a colleague, right? And identifying when would it actually be appropriate to say something and how would you actually approach it. First of all, I just want to say, of course, it depends on the relationship, right? So if this is someone that's on the opposing counsel, maybe it's not appropriate to go up to them and say, hey, your behavior is concerning. There may be a time when that is appropriate. So it is a case-by-case basis. But one of the things that I would say and what I'm trained in is a thing called motivational interviewing. And, I think that just kind of generally thinking about, can you be open to say, hey, is there something going on? Asking the question, being gentle, being honest, and saying, hey, I'm concerned about you. Is there anything going on lately? Acknowledging that you guys have this fabulous program out here, and you can always point them in the direction to reach out to Dan, reach out to the Wellness Members Program, and know that there are confidential solutions and options out there that are specific to attorneys. Another polling question. How many of you would feel equipped to provide 2 suggestions for a friend or colleague if they came to you for help? Nice. Awesome. In the room, we have about, 7 people who feel like they would have some resources, which is pretty awesome in a group of 10. So, and I hope that this conversation that I'm sharing with you guys today can give all of you in the audience at least 2 solutions for suggestions for help for a friend. And we'll wait. Okay.
87.5% said yes, I do, and 12.5% said no, I do not.
That's awesome. Well, I really appreciate that. That's a good amount of people saying, yes, I have some solutions. I have some options for directions to point people if they were struggling. So there has been this myth historically, and there was certainly this myth 10 years ago when I got into the field that rehab was the only way. 28 days, and we get this in the media, right? It's kind of our primary educator in some ways that we see, right? People have seen 28 days. You might have watched the HBO show on addiction. Some people get fascination with intervention. And all of that media reinforcement is talking about inpatient rehab for the most part. And I know certainly when I was looking for support for my loved one 12 years ago, at that point I was thinking, okay, I'm going to find the best inpatient treatment. We're going to spend $30,000 on it, and they're going to go to treatment, they're going to get back, and we'll just resume normal life, right? And unfortunately, that just wasn't the case, And what I found out was that as I started diving in and actually navigating this crazy web of addiction and recovery solutions, there are a lot of options out there, right? So not just a lot of options for treatment, but also a lot of definitions of what is recovery. So maybe some of you guys are like me out there. Before I got into the field, my thought was, as long as this person is not drinking, that's recovery, right? It doesn't matter. And maybe that person's drug of choice isn't alcohol, right? As long as that person isn't using their drug of choice, maybe they can have a beer from time to time. There are a lot of these myths that we kind of live with day to day, right? I hear it all the time with treatment. People come into treatment, they say, heroin's really my problem. All right, we're going to treat your heroin addiction. We're also going to treat every other mind and mood altering behavior that you might be doing. But they might say, well, you know what? I've never had a problem with cannabis, and weed's not addictive anyways, right? And so we have this other complicated issue of it's not just one substance. It's looking at how substances impact the brain altogether. They tend to actually all activate that pleasure center at the back of our brain, which is our limbic system, and that lizard brain, right? It's our reptilian survival skills, survival response. That is where substances are impacting our brain, no matter what the substance is, right? So first of all, we have to get on the same page on what is recovery. I have lots of friends that have been in recovery for years. I have loved ones that have been abstinent for years and don't work a recovery program. There's a wide breadth of how people kind of make their way in the world when they're struggling with a substance use disorder. My personal bias is that recovery means looking at, yes, getting sober and no longer using the substance, and then also kind of treating those underlying issues, those other complex issues that have provoked the use, right? So learning how to treat stress management, learning how to get our anxiety fully treated, learning how to get the depression treated, all of those pieces that contribute to the use comes with recovery. So I want to talk a bit about definitions and levels of care, and I will spend quite a bit of time on this slide because this is where I hope that you guys can, again, come away with more than two solutions possibly at the end of the day. So first of all, just kind of do nuts and bolts, and then I'll go through them a little bit more specifically. So you may have heard of detox or a hospitalized withdrawal. That is really appropriate for someone who has had a physiological dependence on a substance. Some people may not know, but opiate addiction is actually not something that you can die from. You do not need a medical detox from opiate from opiates, but most people will tell you, and if you've ever known an opiate addict in withdrawal, they may not die from that withdrawal, but they sure will tell you that they're about to, right? They feel like they're going to. So there's certainly comfort in medical withdrawal for opiate addiction. But the two substances specifically that people can die from and do require medical withdrawal are alcohol and benzodiazepines. So all of our anxiety pills like Valium, Xanax, all those good things. So that's kind of when it's appropriate for detox. Some inpatient facilities, residential facilities, kind of what we think of as rehab, some of those facilities include detox, and sometimes you can do a medical detox without going to a residential facility, so there can be standalone detoxes. Actually, lately in the last, I would say, 7 years, there are more and more outpatient detox facilities available, particularly for opioid addiction, and occasionally people will do a benzodiazepine taper at the detox level at an outpatient level of care. Those are very medically monitored. Then we have outpatient. So outpatient is kind of a broad definition. That can be a lot of things. It could be outpatient therapy, so just seeing a therapist. It could be outpatient at a treatment center, similar to my own, that I work at, or it could be something more like a day treatment program where you're going in and spending a little bit more time. We also have intensive outpatient programs out there. Some of you guys may know this if you are working with any deferred prosecution or are in the legal field working with DUI specifically. But intensive outpatient is categorized as 72 hours within a 3-month period. So typically we see 9 hours a week over 3 months. And that is both a combination of psychoeducation, group process psychotherapy, cognitive behavioral therapy. More and more the field is giving us this research that mindfulness can be really supportive, and so that's getting integrated more and more into intensive outpatient as well. And then we have residential treatment. So residential treatment, again, there's a wide variety. And when I think about my experience working in felony drug court in particular, for folks that don't have resources, residential treatment and getting access to residential treatment can be a lot more challenging. There's certainly facilities in the state of Washington that take state funding. There's usually long lists to get those folks into treatment at a residential level. So I don't know about you guys, but if you think about someone who comes, when I think about someone who comes into our door and says, hey, I'm motivated, I'm really struggling, I need support, and I say, okay, let me get your name down and I'll call you in about 3 months. It's unlikely that person, when I call them in 3 months, that they're going to say, cool, get me on a plane, let's go, right? So it is a real issue in our state and really throughout the nation, getting access to residential care. And just to give you guys a bit more of an understanding of sort of who would qualify for these levels of care, I will go through that now a little bit. So when I think of residential, and actually just kind of generally the lens, when we think of what is the appropriate level of care recommendation for any particular person who's struggling with a substance use disorder, we're looking at what is their home life like? Is it a situation that is supportive of this person staying sober? So I work in South Lake Union. We tend to have a lot of clients that work at Amazon and some of the other tech facilities down there. Facebook's right next door. And those are hard environments for people to stay sober. When there's a lunch happy hour or a work event that's at Fremont Brewery, it's quite challenging for folks to say, in super early recovery, to say, hey, I'm not drinking, I'm in recovery, I'm trying to stay sober, or no, thank you. All of those options are kind of hard in and of themselves. So we're looking at one, what's that recovery environment looking like? Do they have a work dynamic that's supportive? Do they have a home environment that's supportive? And that can also be problematic. Maybe their loved one is also a problematic drinker or user. Maybe they're living with roommates and their roommates are using, or there's a lot of high access to substances. Any of those things can really contribute. Sometimes on the other side, we can look at the strengths of a recovery environment and say this person really has a lot going for them. They have loved ones that are supportive. Maybe they have a family member or a friend who's already in recovery and working a program through AA, and they have access to that. They know about it. Or maybe they've even had clean time in the past and they have a framework and they can rely back on that program, right? So we're looking at recovery environment. We're looking at someone's motivation and their willingness to change and adjust their behavior. Which, again, kind of looking at this issue of co-occurring disorders or multiple substances being on board, many times people will say, motivated to look at my drinking, motivated to look at my heroin use, motivated to look at this one drug of choice, but this other drug's never been a problem. I've been taking my Xanax for 35 years as prescribed, right, at 2 milligrams, right? Like, this can be a challenge. So we look at motivation for all substances. We look at motivation to recover. And then we look at relapse potential. Relapse potential, I always explain it as kind of a multifaceted issue. One is its awareness. So what do I know? I know that these are my triggers. These are my warning signs. So not just when it's 5 o'clock and I feel like going and having a glass of wine, but also when it comes to warning signs, I want to look at what my own behaviors are that show the world and myself that I'm struggling, that I'm on edge. So I always make this joke because I can't go to bed without a clean kitchen. And so if I go to bed without a clean kitchen, that's a warning sign for me, right? And it's a pretty benign warning sign, but it's looking at what do we know and what can we pay attention to say, I need to reset and check it. And then we're looking at someone's mental health. As you guys have, I'm sure just if you've been here throughout the day, we hear this all the time. Mental health and addiction, they go like this, right? Chicken or the egg, it doesn't matter which. Most of the time they go hand in hand. So self-medicating is a term for a reason because many of us, if there's a substance use disorder, there's usually also a mental health condition going on. Not all the time. Occasionally we get just a pretty simple case of someone who drank too much, right? But most of the time there's something else going on. There's high rates of comorbidity with PTSD and addiction. And when we're looking at mental health, what we want to be identifying in terms of level of care placement and what is going to be appropriate for this person is, is this mental health stable, right? If someone is having hallucinations and delusions, obviously they're not stable, but we also look at stability in other terms and more, even kind of more nuanced terms, I would say, such as when they're really emotionally dysregulated, when we're struggling, when we're having high stress, what do we do with that? Do we have some supports in place? Is there a mental health practitioner that they're working with? Is there a medication that they're taking that's helping them out? And if so, or if not so, how can we intervene and make sure that those things get put in place? We look at biomedical conditions and how those things have been impacted by addiction. Occasionally that can kind of push someone into needing residential or outpatient. And then we also look at general withdrawal potential and intoxication potential. So with that intoxication and withdrawal, if someone cannot stay sober, I always say this to people, we need 48 hours. So if someone can get 48 hours clean, I don't care how they get it. If they can get 48 hours clean, we can get them into outpatient care. But if someone cannot get 48 hours clean, what that shows us is that residential is going to be a more supportive environment for them to really get the clean time that they need. So we're looking at all those 6 dimensions, kind of backing up a little bit, looking at those 6 dimensions of withdrawal, biomedical, mental health, relapse potential, the readiness to change and willingness to change, and recovery environment. We look at, kind of take this big picture scope of everything that is happening for this individual, and then we make a determination of what would be the appropriate level of care. Of course, I work in outpatient, so that's my bias. I love it. I think that's where the real work happens. And what I like to also say about outpatient is that it can be a soft start. So when I think of intensive outpatient or even outpatient treatment, so many people have this idea in their head that someone has to meet rock bottom and hit rock bottom before they get well and before they take that step into recovery. And I don't believe that to be the case. I've seen a lot of people get sober from deferred prosecution. I've seen a lot of people get sober because their family stopped enabling them. I see people get sober because they said, I think this just may be a problem, right? They're maybe not having all the consequences yet. And so in that case, I like to think of intensive outpatient as that soft start, or even outpatient as a soft start. Sometimes people can come in, we say, let's try it out at outpatient. They're struggling. Then we escalate to inpatient treatment. And again, one of the benefits of that, I always tell parents this, if you can start with outpatient and your loved one gets to see that they're struggling and they can't stay sober, then they get to have that information for themselves, right? Because otherwise there's this kind of thing in the back of our head with human behavior change where if we don't try it out ourselves, we just don't believe it, right? And human change, like behavior change in general, is so challenging. There's a reason that gyms make $1 million at the beginning of the year, and then by March, no one's there anymore. It's really, really difficult for us to have sustained motivation for change. And so, one of those factors with sustained motivation is that we have to get reinforcement from that change. And I think that's one of the things that really contributes to relapse is that folks begin to step away from their substance use. They're maybe abstinent, but if they're not looking at addressing all those other underlying issues, they're just now someone who's abstinent and miserable, right? And so we want to have someone be abstinent and happy, or at least content, or able to live with themselves. We can take any of those realms, but not miserable, right? The misery is the thing that's going to loop us back into the behavior. Moving quickly here. I think I might just open it up to questions just to see if there's anything coming in, and then I can kind of riff off of that a little bit as well. But I can fill our time in addition as well. Any questions from you guys live? Yeah.
One second, actually.
You mentioned that you had seen some people successfully transition out of their destructive hobby without crashing to the rock bottom. I haven't. What is it that you're seeing? What is the tell that lets you know, this person doesn't have to completely burn it down to explore getting well?
Mm-hmm.
is there something that you observe that's different in the person that will get off an early off-ramp and others that have to crash entirely?
That's a great question. I appreciate that. I would say that the key factor is someone having motivation. So, we do this thing called motivational interviewing as clinicians, and I think of it as the ninja mind trick of getting in touch with someone's motivation to recover. And so if someone can be in the room and have a good experience with recovery and sobriety, and even if it's, they're court mandated or their family saying we are doing an intervention and you got to be there, if they can have a good experience in treatment, and a clinician, like we hear this in the field as well, that the clinician bond is sort of key, that clinician-patient relationship. If that bond is there and people can hear someone's motivation, even if it's just for this one moment, most of the time I think that's sort of the crux, is if someone can stay in the moment and have an experience in recovery that's positive, we see that they may be able to maintain sobriety a little bit longer without having to hit rock bottom. And that's one of the things we really are passionate about in the place that I'm working, is that we really want to make sure that no matter what brings someone into treatment, they have a positive experience with it, because we know that relapse happens. And so we want to see that even if they end up relapsing, we want it to be a positive experience for them to, be able to come back ultimately if they do struggle down the road. But I would say the main thing is kind of that willingness to have an experience with recovery. People do need to have some perception of consequence. And, for whatever reason, sometimes that consequence that's good enough is the relationship with their spouse or their work dynamic being, having an employer say, hey, I'm concerned about you. Sometimes that's enough. And then other times we see people lose everything before they get there. So certainly case-by-case basis. I think she's bringing the mic over.
Thank you so much for being here.
Absolutely.
I've been doing family law now for probably over a decade, and what I'm seeing is a real common diagnosis of schizophrenia, and usually coming along with some substance abuse, like, for instance, a relative of a worker or a coworker has a daughter who's 17 and was suicidal multiple times. We thought it was just the substance abuse, but it turns out there's an underlying schizophrenia. And I guess my question is this dual diagnosis of some other mental illness alongside with substance abuse, whether it's alcoholism or drug addiction, it doesn't really matter. Are you seeing that more prevalent in the time you've been working in this field, or is that just possibly something that's come across a radar more often? But I see it in clients' families, coworkers, my own family, just like this amazing dual diagnosis. Whereas when I was in law school, I was fortunate enough to do an internship with Judge Larson down in Eugene. So for 6 months, I was in his courtroom 40 hours a week. And the dual diagnosis recovery down there was phenomenal, but I don't remember seeing a lot of schizophrenia or extreme mental illness conditions.
So the question is more, is it becoming more common that there's a more severe mental illness in combination with the substance use?
Yeah, or a mental health component, whether it's the adolescents, the young adults, or the adult people struggling with recovery issues.
Yeah. I certainly think there's more of a spotlight in the since I've been in the field. I remember actually being in grad school and reading a little bit about trauma. And because my lens was looking at substance use issues, I was thinking, man, these things seem to go together. And around that same time frame, all this research started pouring in, right? That we see that trauma and addiction are just hand in hand. And actually the treatment of trauma and addiction, when you can do it together, can be quite successful. And so I think it's been more in the last decade that people are putting light on it. I actually think that mental health and addiction have always gone hand in hand. It's just that it's not gotten as much care or attention. And that's actually been true even in the program of Alcoholics Anonymous, I think. And it's been like we're just treating the addiction. But I think there's been a little bit of a broadening and opening around that as well. But absolutely, I think that it is something that has been there. I think it's just becoming more of something that we're talking about, and then also something that we're seeing and spending our time and attention on. Yeah. I also just want to throw out there, which I didn't spend much time on this, or actually really any time on cannabis addiction, but cannabis addiction has also, we actually got a new DSM criteria of cannabis withdrawal with this most recent DSM. And one of the things that we're noticing, I mean, being in Washington State with the legalization, it's been absurd and really quite shocking how much, just how many people are coming in identifying that cannabis is their drug of choice. That in and of itself has been kind of a shock. But then also to see the impacts in terms of mental health. People are coming in with psychotic disorders, psychosis that are induced by cannabis use, and the types of the method and ways that people are using cannabis as well. It's a whole different substance. It's been a big learning curve, I think, for folks that are in the field. And I know actually for the legal field as well, when we're talking about impairment while people are driving while under the influence, we just don't have a good definition. And so people are, on both sides of this, so I understand it's kind of controversial, but people are driving under the influence, and we don't have a baseline to say, yes, that was impairment, or no, that wasn't impairment. And so people can be completely high and driving and are ultimately getting let go with no consequence. Side note, yes?
Of online
Great.
questions. The first one is, how does this analysis apply to smokers who are slowly killing themselves? Which levels of care do you recommend for a pack-a-day addiction?
Man, isn't that the question? I wish I had a good solution for nicotine cessation. As we notice in this field, I mean, we can't get inpatient facilities to go nicotine-free most of the time because people just will go to another facility. Even at an outpatient level of care, we've had clients really come to us and say, which I think is awesome, we have clients come up and say, okay, so you're telling me that I can't mood alter with all these other substances and that would be considered relapse. But if Johnny over here decides to start smoking while in treatment, that's not considered relapse. And I think that, there is this issue, right? We're struggling with how do we deal with nicotine? How do we provide good intervention? Historically, it is really one of the most difficult substances for people to quit. And there are good resources out there, but I will tell you I'm not an expert. In terms of inpatient treatment for nicotine, most of the time insurance won't cover it. And so even though I think that could be beneficial, it's not something that's out there right now. We see people get success with sort of the medication-assisted route with some craving assistance with medication. Sometimes there are support lines that can be helpful. And then if people are in outpatient or inpatient treatment, they may be put on the patch or something like that. And we do see that it can be quite useful just to be talking about craving, talking about the urges, same things as we would do with any other substance while in treatment.
Okay. Second question. With the various treatment programs available, including online, what credentials are essential for a treatment program?
Credentials. I think, it's a good question. There really are, there's such a wide breadth of treatment out there. And this is something that Dan mentioned, right? And I feel this even being in the field and being very close to a lot of treatment providers. I change who my preferred providers are pretty much quarterly because, different people come into the facility, different people are running the facility. All of those things can trickle down and impact the care that people are providing. Something you can look at is this facility accredited? There's JCO accreditation, there's CARF accreditation. Those are kind of the gold standards, and they're saying, those accreditation bodies are coming in. They're saying, yes, you're doing good treatment. Those are expensive things to pay for to have your organization have. But I do think it does give that kind of stamp of approval. But I think generally you want to make sure that I would just say call them and get your questions answered and speak to several people who have gone there. You can ask and say, hey, can I call an alumni? If they say no, you might wonder why. Yeah.
One more.
Of course.
So should an addict attend a 12-step recovery program?
This is, of course, an issue of bias, so I will just put that out there. But I absolutely believe in the 12-step program of AA. I went through the program of Al-Anon myself and went through the 12 steps through Al-Anon myself and found it incredibly useful. I'd been to years of therapy. Nothing I did in therapy, I am a therapist, but nothing I did in therapy changed my behavior like working a 12-step program. So that's my bias, but I will also say that one of the things we see with treatment is that we provide this big container, right? We're going to just give this person all the support that they need for 30 days, then maybe they step down, they do IOP, they do outpatient, and then if they just are done and there's no continuing care, there's no ongoing support, what we find is that people really struggle. And ultimately, that's about having a community of support. And so if someone's really struggling and bumping up against a 12-step program, we're going to say, go find something else. There are lots of other supports, especially in Seattle. We're so fortunate. It's a big city. There are other things. There are other options. There's refuge recovery. There's a Buddhist recovery program that's going on in Seattle. There's smart recovery. There are options. Celebrate recovery. And those things are out there. They're great. They're good resources. Even for folks that are in AA, they can be great resources. But the main critical factor is having a support group, having someone or someone's preferably that if you're in a crisis, you can pick up the phone and call. And this whole thing with AA, and it's really kind of magical, and I know that's not very sophisticated to say, but it is something really powerful. We're human, human interaction, we need connection. And so knowing someone who has gone through the same experience as we have, if you think about as you came into your professional career, if you didn't mentor under someone who was doing what you did, would you be the attorney you are today? If I didn't get supervision from excellent clinicians before me, I wouldn't be the clinician I am today, right? So it's having someone who can say, yes, I've been there, I've had that problem, and here are the solutions I found effective. So it's all about kind of that mentoring and connecting. Sure, great.
Particularly with nicotine addiction, do you ever find people who go anti-smoking to the extreme? Example given, take up a running regimen and really go whole hog, ultra running, marathons, etc. Is that much of a problem or easier to address than the underlying addiction or the initial addiction?
I think that this is actually an issue we see in treatment a lot. It's not specific to nicotine addiction, I wouldn't say. But what we see is this kind of we call it whack-a-mole, right? So we got the heroin addiction, and that's under, we're okay, that's in control, 30 days clean. Oh, all of a sudden, marathon running, right? And so there's this impulse because it's a good one, right? We're getting dopamine, we're getting this kind of feedback in our system, and the question is it's kind of everything in moderation, and addicts and alcoholics don't like anything in moderation, right? And so we're looking at and ultimately it's about motivation. What is it in here that's prompting that behavior? Is the running, is that becoming a mood-altering activity? Or is that just like really you're staying fit and you're feeling good and you're not doing it to change what's going on in here? So when I think of recovery, it's like I've got stuff in here, I've got resources, maybe outside of myself as well, but in here, I'm doing okay, right? Addiction and other problematic behaviors, gambling included, it's like I need this to make me feel okay, right? And so anything, whether that's shopping, gambling, running, eating, all of that stuff, we see it all pop up at treatment. We treat a lot of co-occurring eating disorders and mental health disorders and gambling disorders. All of those things may show up while someone's trying to get sober. Any last questions? Okay. All right. Well, thank you guys so much. I really appreciate the time today and all of you.